Hi, my name is Brian. This is my last video presentation on the obstructive shock, specifically a cardiac tamponade. This is video 5 out of 5, and let's get to it. So, a cardiac tamponade is a clinical syndrome caused by the accumulation of fluid in the pericardial space, resulting in reduced ventricular filling and subsequent hemodynamic compromise. The condition is a medical emergency, the complication of which include pulmonary edema, shock, and death. And as you can see, here's a nice little example of fluid overload in the pericardial space. You see the heart silhouette, but then this huge amount of fluid building up and all these vascular markings as well that is overloaded in that as well. So what are some symptoms that we can keep an eye on as RTs? Well, these happen very acutely, and the underlying cause of the tamponade. Patients with acute tamponade may present with dyspnea, tachycardia, and tachypnea, which could present as cold and clammy extremities from the hyperperfusion and are also observed in some patients. Other symptoms and signs may include the following. So the patient could have an elevated jugular venous pressure or pulsus paradoxus. They could have increase, or they can have complaints of chest pressure. You'll see a decrease in urine output. They would be confused. Their sensorium isn't there, and dysphoria as well. So just to dive in to explain a little bit about it, the pericardium, which is the membrane surrounding the heart, it is composed of two layers. The thicker pericardium is the outer fibrous layer, and then the thinner visceral pericardium is the inner serous layer. The pericardial space normally contains 20 to 50 milliliters of fluid. So there are three phases of hemodynamics changes in the tamponade, and it's as follows. So you have phase 1. This is basically the accumulation of pericardial fluid, which impairs the relaxation and filling of the ventricles, so they have that less space to open and contract, which is requiring a higher filling pressure. During this phase, the left and right ventricular filling pressures are higher than the intrapericardial pressures, which is not good, because then you have this overload of working that the heart is already doing, and again, the heart is already beeping every single minute or every single day, so now you have this buildup of pressure that's going to continue to go forth. So then you enter phase 2, which further is accumulating fluid. The pericardial pressure increases above ventricular filling pressure, and thus you have an overwhelming of it. So now your ventricles are not filling all the way in because of that pressure it's surrounded in, and in turn reduces the cardiac output. Then you're into phase 3, which is the last phase, is a further decrease in cardiac output, and which, due to the equilibration of pericardial and the left ventricular filling pressure, just decreases, and then that pressure just continues to rise. So one thing to know is pericardial effusions, which cause cardiac tamponades, can be serious or serious sanguineous, hemorrhagic, or childless. So you're in this tricky situation as a patient, and as an RT, it is very important that we get a prompt diagnosis to reduce the mortality risk for the patient with this cardiac tamponade or this obstructive shock. So although echocardiography provides the useful information, a cardiac tamponade is a clinical diagnosis. Echocardiography can be used to visualize ventricular and atrial compression abnormalities as blood continues through the heart. So the following may be observed with the two-dimensional echo. So you have an echo-free space posterior and anterior to the left ventricle and behind the left atrium, the early diastolic collapse of the right ventricle free wall. You'll see a light a late diastolic compression / collapse of the right atrium, so everything is lagging behind, swinging of the heart in the pericardial sac, so you'll see it kind of moving, kind of like vibrating in its position where it should not be. Left ventricular pseudo hypertrophy, so then you have this thickening of the left ventricle, and then the inferior vena cava plethora with minimal or no collapse and inspiration, which is not something you see. This it's not supposed to not happen. It is supposed to happen. A greater than 40% relative inspiratory augmentation of the blood flow across the tricuspid valve, and then a greater than 25% relative decrease in inspiratory flow against the mitral valve. So then you have these differences in flow percentages for each of the valves, the mitral and the tricuspid. Just to name a few, talking about etiology, for all patients with malignant diseases are the most common cause of pericardial tamponade, which is between 30 to 60% of all cases, and a tamponade can occur because of any process that causes pericarditis. And pericarditis can result from the following: human immunodeficiency virus, HIV, infections such as viral, bacterial, or fungal infections can cause this to happen, and of course, any drugs overdoses like hydrolyzine, procainamide, isoniazid, I can't even pronounce it. So those drugs as well. So any imaging studies that aid in the diagnosis of the obstructive shocks, such as a cardiac tamponade, we'll be going through those as well. So as we touched on before, one of the main things is an echo. Patients with suspected cardiac tamponade should undergo an echo without delay. After diagnosis, patients are scored according to disease etiology, clinical presentation, and imaging findings. So a score of 6 or more requires patients to undergo immediate pericardial drainage, or if it's slower than that, usually that can be postponed, see if it works on its own. Sometimes it might not most of the time, so then it gives the doctors, the patient team, the care team more time to adequately prepare for that. But as you can see here, the collapse of that right ventricle and that pressure from that pericardial space here. So you have that pericardial space just full of fluid, way more than the normal, and then these right atrium, left atriums are just super overfilled, and then trying to get through that pressure here is almost close to impossible. So conditions that may simulate a pericardial effusion on a 2D echo include the following, and here they are: large left pleural effusion, any tumor, a mitral annular calcification or like the stenosis of those valves, descending thoracic aorta, a catheter in the right ventricle, and a large left atrium, annular swab, annular subvalvular left ventricular aneurysm, and a bronchogenic cyst. And as shown again, CT scans can show the cardiomyopathy, that water bottle shaped heart, and the evidence of chest wall trauma, as you can see here, is just completely separated, completely pushed away. In here we have a CT scan, and as you can see, there's fluid buildup in that pericardial space here, and then you have all these pushing against that ventricle here as well. So any monitoring techniques for hemodynamics and values relevant. Of course, you'll have your cardiac monitor, your pulse ox reading the saturation levels of your tissue oxygenation, but more invasive maneuvers would be like a Swan-Ganz catheter, which can be in place, left in place for continuous monitoring for hemodynamics and to assess those pressures in those hearts, ventricles, and atriums. and also in those great vessels. Cardiac tamponade is a medical emergency that requires urgent drainage of the pericardial fluid. So after a pericardiocentesis is done, usually they leave that intrapericardial catheter in place after securing it to the skin using sterile procedures, so that it has a closed drainage system through through a three-way stopcock. So periodically they will check on that to reaccumulate fluid and drain as much as needed, because usually it's not something that goes away right away, but it does help resolve it. So we are very limited in the role of medication therapy to treat cardiac tamponade, but IV fluids, vasopressors can be used temporarily, but invasive approaches such as surgical pericardiocentesis is usually the standard of care. Dobutamine is an inotrope, which can improve cardiac output, and that's what we need, try to have that heart kind of work against that pressure. But again, it's a two-way sword, so you're putting a lot of stress on that heart ventricle as well. Beta-1 receptors stimulate agents, increase stroke volume and cardiac output as well, which is good for the heart to really push up that volume. You can start to see a very profound arterial respiratory alkalosis during cardiac tamponade, since you have a high PCO2 levels, because you're not getting that perfusion and you're not ventilating as well as you should be. Then you're declining oxygenation wise. So positive pressure mechanical ventilation should be avoided, because it may decrease venous return and aggravate signs and symptoms of the tamponade, and that could put a huge strain on that, and it can further deteriorate cardiac output already compromised by the tamponade. So we want to make sure that we're not exacerbating the symptoms of the tamponade, like low BP, paradoxical pulses, or respiratory distress. So let's try to consider alternate options, such as managing the cardiac tamponade, like immediate pericardiocentesis or the fluid drainage. And if necessary, of course, high flow oxygenation will be needed to try to overload our system with oxygen as they try to assess this and fix and correct this surgically. So here's my reference pages, but just to give a summary over it again. But a obstructive shock is an example of a cardiac tamponade, and cardiac tamponade is basically just a overfilling in the pericardial spaces that can cause pressure and constrict the ventricles and the aorta and the great vessels from actually delivering the blood that we need. This in turn can cause ABG levels to spike, such as CO2 rising in it, so causing acidosis to occur, which can happen pretty fast and quickly. We also want to keep note that one of the only main surgical treatments is a pericardiocentesis, and we can tell that by either an echocardiogram, which is the best way to clinically see the amount and where it will be best to drain it from, and even then to continuously monitor and drain from that inline catheter that is in place. But yeah, it's a high mortality rate, and it is very likely for patients to succumb to that a lot easier and quicker if it's not immediately grasped and treated right away. Well, as RDs, that we also take into account that we need to put the patient on a high flow oxygen delivery device without any mechanical ventilation needed, but most likely they will be on mechanical ventilation just with lower pressures to not try to add more pressure to that great vessels or on the heart itself. All right, well, thank you again, and thank you for joining me today.